We have a focus on eConsult specifically today, and then moving into an overarching meeting on telehealth tomorrow. And it's great to work with our partners with this California Telehealth Policy Coalition. So Rob, you want to walk through that agenda?
Sure, I'd be happy to, Libby. So we welcome all of you to join us tomorrow for the California Telehealth Policy Coalition's annual meeting. That meeting will be co-hosted by the Center for Connected Health Policy. And really, we're looking forward to another packed agenda for the day. A couple of highlights. We'll be having a speaker from the Department of Healthcare Services, Renee Malo, speaking in the morning to give us a sense of where the Department of Healthcare Services and Medi-Cal plan to go next year when it comes to telehealth policy. Additionally, we'll be hearing at 9:50 from Assemblymember Cecilia Aguiar-Curry, who last year authored AB 744, which was the payment parity bill for telehealth for commercial payers in California. And we'll also hear later in the afternoon as well from Dr. Alice Chen, familiar to many of us here in the eConsult Workgroup, who is a longtime eConsult champion. She's now a deputy director within the California Health and Human Services Agency, and this year is being presented with the State Champion Award, and we'll also give some remarks as to where CHHS is headed next year. And additionally, we'll be having our friends from the Veterans Health Administration, including Drs. Susan Kirsch and Ken Kaiser, on as well for a lunch and learn to learn more about the Veterans Health Administration's experience with telehealth during COVID-19. So with that, we hope you'll join us. Please let us know if you're having trouble registering or would like more information on the event, and we're happy to provide that to you. So thank you, and I'll pass it back to Libby.
Thanks, Robbie. Actually, I am going to pass it back to Timmy Leslie, who's going to introduce our next panel on addressing current challenges. So we'll take a minute and have that panel rejoin us by video. And as we are jumping back on after hopefully everyone got a brief lunch break, we'll let our panelists join us, and I will hand it off to you, Timmy.
Thank you. Thank you, everyone. And let's see. Oh, I'm seeing some familiar faces. All here. Well, just moving, I think, with the theme of the day, you could see there was a little bit of method to our madness of emphasizing provider engagement, payer alignment, and also looking at how we are able to push forward and helping to scale eConsult. Our afternoon session is going to be focused on some of the key areas that we'd like to be able to tackle and hopefully tackle together next year. One is, and as Dr. Nwando eloquently described this morning, that we need to be able to put eConsult at the center of being able to reach equity and justice, and that will be Dr. Payan's remarks. And then we'll move to a good friend of the eConsult Workgroup, Andrea Fry, who will walk us through some of those key issues that typically come up when organizations start an eConsult program around consent and liability. So she'll be here, and hopefully we'll be able to take questions as well that some of you may have that she can address or also look at after the session. And then we have our esteemed panelists of the VA leaders, Dr. Kirsch, who is the acting assistant deputy for an undersecretary for health access at the VHA, and has been spearheading and leading the effort of eConsult at the VA. And we're just so happy to have her here, especially under the circumstances with the pandemic, to be able to address the real leadership that the VA is demonstrating, and hopefully we can emulate and follow. And also Dr. Kaiser with Atlas Research and also has been working with Dr. Kirsch on the access issues at the VA and research there. Will be joining Dr. Kirsch in the panel, and also Dr. Afrons, who has been at the front line with working with and utilizing eConsult. So we have a fantastic session, and I am going to hand it over to Dr. Payan, who will then walk us through her work that she's doing at UC Merced. Dr. Payan.
Hi, Timmy, can you hear me?
We can, thank you.
Okay, great. So hi everyone, good afternoon. I hope you are blinking off the screen, taking a break from the Zoom fatigue. And then as you come back, I'll just be talking briefly about equity in eConsult and telehealth more broadly. And actually I was able to join some of the morning sessions, including the Stellar keynote, where we've already seen really critical issues that are related to equity in eConsult really eloquently stated. Prioritizing equity as a value in eConsult and telehealth services more broadly is what I'll talk about. But the importance of documenting patient experiences, patient engagement, documenting improved outcomes related to patient experiences with eConsult, right? These are really key to reimbursement, is something that I was hearing. And then the keynote message really pushed out of health services research a little bit, but also talked about civic engagement and various really commendable strategies that are clinical community linkages that we really need to promote and think about equity and bring the community and patient perspectives into these technology-driven pieces. So I really love that message. I'm glad I got to hear that, technology as social justice. And so today, to introduce myself, I am an assistant professor of public health and a health policy researcher at UC Merced, and I run the Community Health and Innovative Policy Lab, the CHIP Lab at UC Merced. So I wanted to start off with just this broad definition of health equity that the CDC and various other organizations have been including and promoting. So health equity is achieved when every person has an opportunity to attain his or her full potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. And so this actually, think about the patient. There's been this larger movement of patient-centered care and patient-centered outcomes. But something else that comes with that is the patient brings, as well as the clinic providers and staff, we bring in our outside circumstances, our social norms. And so how do we balance and think about these social conditions? I won't make an argument for the social determinants of health. I think everyone here probably, we already accept that. But how do we actually take steps? And this year, during the pandemic and moving forward, how do we take steps to incorporate and think about the social conditions and other conditions of individuals and how it affects their communication, their interaction, and their relationships? And today I'll focus more closely on health services and eConsult. And some of the, in my teaching and in my research, some of my overarching goals really are, to actually not be so narrowly focused on health policy as healthcare policy, but health policy as public health and healthcare policy. But today I'll actually have done some work in health communications and research on clinical community linkages. And just this year, I'm collaborating on a telemedicine study. So I will actually focus on those three areas more so than my other health policy research. And I am here actually representing, in the next slide, somebody else who is part of the eConsult Workgroup, Hector Rodriguez at UC Berkeley, who is the director of CalIHEA, also a professor at UC Berkeley. And I just wanted to mention this because it may be of use to some of you. So CalIHEA is the statewide initiative that is trying to bridge the gap between UC research and faculty expertise and state policy making. And there are 4 priorities, some of which are related to thinking about and promoting equity in health services, the provision of health services and the delivery of healthcare services. So I just wanted to bring it to your attention that CalIHEA exists. There's a website. I'm the deputy director of this initiative, and these are the 4 priority areas. And of relevance is just in the back of your mind thinking about, the push to build a workforce for health equity is really important. Who is there and providing services and supporting one another for the provision of services. And then addressing social determinants of health through cross-sector collaboration. So we have a great newsletter. I invite you, these areas are of interest, to sign up to receive that newsletter. And we have a lot of webinar events during COVID. So just this week, we have this Expanding California's Behavioral Health Workforce in Response to COVID-19 event, which is free to people who are interested. So the next slide. eConsult is not, I'm not an MD, I'm not, health services research expert, but when, I just learned about eConsult earlier this year, and what it made me think of was actually this, if you remember that telephone game, which is certainly not appropriate for COVID-19, this game where, a child tells another child, and there's kind of a link, a word, and the information passes, and at the end, usually, it's a completely other word. And so, this really simplistic idea highlights miscommunication, issues in communication. And so eConsult, to me, that's the first thing I thought of. It's information flowing in and then flowing back. And so today I just briefly want to talk about this closing the loop and how we can think about addressing and preventing some of these issues in miscommunication. Even in this child's game, it's kind of, eConsult is a modified telephone game. It's information that's flowing and coming back to the patient, but decisions are being made, right? But the language pieces matter, hearing, so someone's ability to hear, so disability factors in as well, someone's comfort, their trust, the relationships that exist. All of these pieces actually in this simplistic game also matter in eConsult and in the use of technology in health services. So in the next slide, I pulled this from, as kind of a visual, which all of you are very probably familiar with, this from AMC, but I wanted to kind of think about this visual that centers a primary care physician in eConsult and in this relationship. And so what I added to this visual to click on it is to think about going back, actually. There's been great recommendations, and the toolkit does a great job of thinking about many of these relationships and how to strengthen that in ways that would promote equity and better patient outcomes. But I want you to think about this relationship when information comes back to the patient. And so some important considerations that I just briefly want to highlight without going into detail is centering, to promote equity, we really should center in the use of technology this provider-patient relationship, the patient, and communication as well. And so some important aspects related to this relationship and how patients take in information and respond is this provider-patient relationship. The level of trust, so as an existing patient or as a new patient. The communication mode, which this year has just drastically changed. We have now phone, virtual, in addition to in-person access to your primary care physician. Language access, health literacy, patient-centered strategies, patient preferences, and just thinking about shared decision-making and documenting how eConsult is prospectively changing these relationships and how patients and primary care physicians, the best models and evidence-based guidelines to promote better care. So in the next slide, I just wanted to I do some qualitative research, so I like centering patient voices. And this is not my study, but it kind of highlights language access issues. So that was something I just really wanted to highlight, is thinking about in California and our Medi-Cal population especially, we have a lot of limited English proficiency patients. And so these two quotes come from a study that was conducted, not by myself, some people that I know fairly well, but in a safety net setting. And I pulled these two quotes from that article because it really does highlight some of these language barriers in the words of patients. So in the first one, these are two patients who are LEP, limited English proficiency, and they speak two different languages in this case. And the first patient says, "I don't know because I don't understand English." And then whatever I tell the interpreter, so it's, this third person, he is relaying the information in English and then relaying what the doctor says back to me. There is the gap. And so I really like that quote because it highlights, the telephone game actually can have another party when it gets back to this interpreter or another individual who is interpreting information. And in the person's own words, it can create a gap, and we need to think about that gap. And then the second quote, the patient's commenting on their experience with a doctor who doesn't speak Spanish and talking about the difficulty and focusing on the lack of clear communication and this concern that their symptoms will not be interpreted correctly because of communication. And so regardless of the new technology and its use, collection of family history data is really, really critical, right, to correct diagnosis, prognosis, and treatment. And so thinking about that relationship and strengthening PCP and patient relationships, particularly for individuals who speak another language, is really critical. I think can play a role in eConsult and the improvements to eConsult. So in the next slide, I just wanted to highlight kind of thinking about COVID-19. We've seen this telemedicine boom, telehealth boom in general that's happened, and something that right now Hector Rodriguez and I are collaborating on a study in safety net settings in the Bay Area, where one of the objectives is actually to document facilitators and barriers from the perspective of the clinics, the clinicians, the staff, who are really critical, and the patients, as it relates to patients who actually have diabetes or cardiovascular diseases and are predominantly Medi-Cal patients, to see and triangulate some of the information to inform policy changes in the next few months. And so, we've really seen this rapid adoption and use, but some organizations were not prepared for that. The organizations that were more academic medical centers were able to do it very quickly. And other organizations that had less resources were able to do it, but frankly, there's a lot of challenges. We're seeing more telemedicine in terms of phone or audio only, which is great, but it's also suboptimal compared to the ideal telemedicine visit. So it's kind of thinking about optimal versus reality and what is happening in reality for different individuals and what care looks like. So that's a little bit, I just wanted to kind of think about that context and bring it up. And we need more research, quick research, and QI work to think about how to improve the quality of care and the provision of telemedicine and other telehealth services for these populations. And so in the next and final slide, I just wanted to go back to this visual and actually bring up, thinking about, a really key takeaway is thinking about this provider-patient relationship and how eConsult is changing the information that's provided, because the PCP now has this added responsibility of communicating back this information. And there are ways to do this more effectively and equitably. And so I added these two pieces. So one of the ways would be thinking about enhancing patient experiences. And there's just a lot of work that's been done in thinking about community health workers, promotores de salud. And they're not all the same, so patient navigators are different than traditional community health workers, and being intentional about the use of these additional individuals and what they contribute to this relationship. And then on the other side, thinking about the way that patient education materials that are communicated, and the eConsult toolkit has great patient education materials that I saw, and some of that is also for your population. Is it literacy appropriate? Is it culturally sensitive? I've done some work with community health workers and patient education materials. And one of the things that a person does that giving someone materials alone we found is helpful, the added value is self-efficacy for that patient in their decision-making. That was for Breast Cancer Prevention Project. And so I just want to highlight these additional considerations as eConsult is being deployed or strengthened. And then the other pieces I won't go into so much. You'll have these slides, but other things would be thinking about the training, communication training, documentation of engagement between the specialists and PCP. Someone said we don't grow providers on trees, but we can grow them in the valley. I'm at UC Merced. We are going to launch a medical school between UCSF Fresno and UC Merced in the next couple of years. We can think about these longer-term capacity building strategies to promote and still address that issue and not stop altogether. So with that, I will stop, but hopefully this was informative and gave you some food for thought about the importance of equity and how we can center equity even in these technology-driven solutions.
Thank you so much. And I think it's great to be able to have your center being able to be part of our work going forward. It'll be really helpful, and also we look forward to all the research that you're doing, and the opportunity to build a medical center from ground up that will include eConsult would be also really terrific. So I'm moving on to Andrea. And Andrea, are you?
Yeah.
There you are. You just
here.
I think we need to see you.
see. It says the host has stopped my video. So.
Oh, well, that's unfortunate.
There we go.
There you are.
Great.
Great, Andrea. Thank you for joining us today and walking through some of the legal and compliance concerns that we know many have when they are starting or in the startup phase of their programs.
Yeah, great. Thank you, Timmy. And just by way of introduction, as Timmy mentioned, I'm an associate attorney at Hooper, Lundy & Bookman in the San Francisco office. And I do a fair amount of telehealth related work. I'm also the co-chair of the firm's digital health task force. And so really happy to be here. Thank you for the invitation. So I've been asked to kind of prepare a quick overview of some of the legal and compliance considerations when to keep in mind when using eConsult. And just, before we dive in, I want to have a quick shout out to acknowledge the resource page that my firm has put together, kind of just compiling guidance around, both from regulatory agencies and internally, including a ton on telehealth. So I'd urge you to check that out. So turning to the next slide, thank you. I'm going to start with a kind of focus on everybody's favorite topic, health privacy. And so first and foremost, as I'm sure you're all aware, the use of telehealth, including eConsult, doesn't in any way change a provider's responsibility to protect the confidentiality, integrity, and security of PHI in accordance with various federal and state privacy and security laws. And so first, we all know of HIPAA, and so that, just as a note, doesn't treat any health information differently. It's all wrapped under it, with the exception of psychotherapy records. But then we also have corresponding state law, the CMIA here in California, the Confidential Medical Information Act. And then we do have other laws like Part 2 and at the state level, LPS, which are focused more on sensitive types of health information, so around substance use disorder records and mental health records. And so in general, just kind of a quick caveat here too, that the more restrictive law applies, but in practice, you do need, assuming these apply to you, you need to keep in mind and comply with all of these. And so, as I mentioned at kind of the top of the slide here, none of these laws contain any special sort of requirements or sections devoted to telehealth. So this means that providers, still need to meet the same requirements for any service that's provided in person as to if it's provided via telehealth or if there's any PHI shared over eConsult. And so whenever a provider initiates an eConsult, any communication between that originator and the consultant, assuming PHI is shared, the method of communication does need to be compliant with these laws. So for example, by ensuring that whatever the platform used, that it does have some form of data encryption, that the vendor, that there's a BAA, a business associate agreement in place with that technology vendor as well. And other various safeguards just to ensure that there isn't any possibility that, there could be unauthorized access to that patient's health information when shared across these platforms. And then kind of a general tip too, that, you should be constantly conducting assessments, both with the vendors that you use, but also internally to make sure that there aren't potential risks and vulnerabilities around your PHI, both in terms of confidentiality, integrity, and availability. And so just a quick reminder too here that a business associate is defined as a person or entity that on behalf of a covered entity creates, receives, maintains, or transmits PHI. But so in practice, what this means is that a covered entity assisting with treatment of patients, so in this case, for example, with eConsult, with the specialist, assuming that they're external to your operations, you wouldn't necessarily need a BAA, but the vendor platform that the specialist uses or that you use in order to conduct eConsult, that would likely be your business associate. And so I also have just a quick note at the bottom here that back in March, HHS and in California as well, after pressure from stakeholders like you guys, both HHS and the governor relaxed a number of state and federal privacy and security requirements just to ensure that the provision of telehealth isn't constrained during the pandemic. And so specifically with HHS, the OCR, which enforces HIPAA, declared back in March that it's exercising enforcement discretion and waiving penalties for violations under HIPAA related to the good faith provision of telehealth. And so, you know, while there is this enforcement discretion right now, I would still, you know, urge you that this is temporary, and it still remains best practice to make sure that you have the, you know, necessary safeguards in place, including the BIA, for example, because at the end of the day, the other remaining regulatory requirements under HIPAA and these other various laws do still apply. So next slide. Okay, and so now just a few quick notes about consent and documentation requirements for eConsult. Generally speaking, patients' written or verbal consent does need to be obtained prior to the eConsult. And so CMS in the final 2019 physician fee schedule noted how it's requiring patients' verbal consent be documented in the patient's medical record for eConsult, basically as a way to give advance notice to the beneficiary that he or she would be liable for any cost sharing associated with these services. And then here in California, DHCS has also noted that it does, there is a consent requirement still applicable to eConsult, but in general, if a healthcare provider has or maintains a general consent agreement with the patient that specifically mentions the use of telehealth as an acceptable form of delivery of healthcare services for that patient, that is sufficient for documentation of patient consent, again, assuming that that's in the patient's record. So as far as specific provider requirements, CMS also requires that eConsult services be billed only by practitioners that can bill Medicare independently for E&M services. And so we have NPs, MDs, but not, for example, RNs. And then as well, for example, with DHCS requires that the Medi-Cal, the originator be licensed in California, enrolled in Medi-Cal as a billing provider or rendering provider or non-physician medical practitioner and affiliated with an enrolled Medi-Cal provider group. Whereas the specialist, though, DHS has noted that it doesn't have any sort of specific restrictions on the distance site where the specialist is located. And it can be different from the administrative location, but the specialist can be located out of state as long as they are licensed in California and enrolled as a Medi-Cal rendering provider or NMP and affiliated with an enrolled Medi-Cal provider group. So, and then just a quick note too, that lastly, I'd urge you just to double check any sort of other documentation requirements and consent requirements with whatever private payers you may be contracting with. And then in addition to that, you know, the Medi-Cal, I have a link in the slide here to the Medi-Cal provider manual, and that has on page 9 specific documentation requirements for the use of eConsult. So for example, the originating provider in the record needs to create and maintain a record that the eConsult is the result of patient care that has occurred or will occur and relates to ongoing patient management, whereas the consultant specialist needs to create and maintain a record of the review and the analysis of the transmitted medical information with written documentation of date of service and time spent, and a written report of case findings and recommendations with conveyance to the originating site. And so, you know, just I'll sort of casually wrap this up at the end as well, but these requirements are super important, not only from a compliance perspective with fraud and abuse issues, but, you know, also from a potential malpractice concern as well. So next slide. This is a good segue into fraud and abuse considerations. So, you know, in the physician fee schedule commentary in 2019, CMS did note that there are program integrity concerns with making separate payments for eConsult services, including, for example, whether or not it can actually evaluate if an eConsult is reasonable or necessary under particular circumstances. So it's definitely important to ensure that your providers are accurately documenting eConsults. And on top of that, I actually, when Robbie asked me to speak about this, he mentioned that there was a concern that many folks aren't billing for eConsult services and whether or not that poses potential fraud and abuse considerations, given, at least in Medicare, that there is a cost-sharing requirement for eConsult for the patient. And, ultimately, just kind of off the cuff, I think it's unlikely that this would pose potential kickback and beneficiary inducement issues. But this is all, it ultimately comes down to a facts and circumstances test. But presumably, as long as providers aren't, waiving these cost sharing requirements as a result or as a way to try and induce the patient to seek further services from them as the primary motive for waiving that, then it's unlikely to pose issues. But again, it all comes down to specific facts and circumstances around the non-billing. And that kind of brings up too that back in March with the start of the pandemic, OIG did announce that it's exercising enforcement discretion and won't be subjecting patients physicians or practitioners to administrative sanctions for reducing or waiving cost sharing obligations for telehealth services, just as long as specific conditions are satisfied. But I think, again, same with kind of the health privacy waivers, this is just going to be temporary. And so given kind of the exponential growth that we've seen in telehealth, and as well, signals that both OIG and DOJ have sent recently that further actions are definitely going to be in the pipeline, it's really important to ensure both telehealth generally and your eConsult practice is carefully structured to avoid triggering any sort of fraud and abuse implications. And so lastly, I just want to kind of summarize these various issues. I think ultimately it's really important that you have policies and procedures in place just to make sure that everyone is on the same page around your eConsult practice. And it also helps in case regulators or a plaintiff comes in knocking on your door, that you can point to as evidence that you're following this, and that you have the proper requirements in place to make sure that your providers are accurately documenting or that they're appropriately licensed and enrolled, etc. And so, with that, I will turn it back to Timmy because I think I'm out of time. But thank you so much.
Thank you, Andrea, and thank you for this useful checklist too. And I'll make sure that we have all these slides out to those that are going to be looking for this as reference, I'm certain. So thank you, Andrea. And now I'm going to move it over to Dr. Kaiser, who's going to introduce the leadership level that has been really forging a way around eConsult across the system, and hopefully we'll be able to bring along our federal regulators and state policy leaders to see the way. So Dr. Kaiser, I'm going to hand it over to you.
Well, thank you, Timmy, and my compliments for putting together such a great program. It's really good to be with you today. I have to just digress for a second. Listening to the program today just reminds me how much things have changed since I was running the former Department of Health Services for California and the Medi-Cal program, and trying to pioneer Medi-Cal managed care a long time ago. But anyway, let me shift gears here. Over the past decade or so, it's become clear that eConsults really are a very effective way of improving access to specialty care. I think here in California, the experience of the San Francisco and Los Angeles County Departments of Health, among others, have shown that eConsults really can reduce wait times. They can reduce the cost of care. And importantly, they've been particularly useful on improving access to specialty care for persons or populations that historically have not had very good access to care. And while the San Francisco and LA County Departments of Health in particular have gotten a lot of attention for their pioneering work in eConsults, another pioneer in this area that has not gotten as much attention is the Department of Veterans Affairs health system. And the VA's efforts in this regard really go back 20 years to when I was the undersecretary, and we started doing more in the area of telehealth. And I'm pleased that we're going to spend the next few minutes talking about what the VA has been doing in this area, particularly in recent years. And with that, I'm going to now turn things over to Dr. Susan Kirsch and Dr. Lisa Arfons, who's going to walk through some specific information about what the VA has been doing.
Great, thank you so much. Can you hear me okay? So I want to share with you a bit about our journey since 2012 when we did start implementing eConsults. And keep in mind that we have had this experience since 2012, and some comment to the prior speaker is that in our system we take care of 9 million veterans. That's our members, our covered lives, and we have allowed eConsults because we in some ways govern ourselves around some of the rules here. We have nurse practitioners and physicians. We also do have clinical pharmacy specialists as well as psychologists doing some of the eConsults, so can follow up with some further information as need be. I'm going to share some of what we have done and learned and then turn it over to Dr. Arfons, who has had personal experience as a medical oncologist and a specialist doing this work. So what have we learned that is useful and maybe potentially applicable to many of you? Perhaps there are similarities or differences, and really looking at cost as a consideration to help drive further implementation. And as we think about this during the COVID time period, and we'll demonstrate that we have escalated use of eConsults, I think there must be some consideration for what would it take to keep this work continuing and maintaining, sustaining and maintaining this work for a number of reasons. So if you could go to the next slide, please. We recognize that in non-VA world and private sector that some additional coding modifications came out in January, and that we adapted and adopted some reporting back in the medical record as our way of addressing some of the verbal reporting. We did not end up mandating some of that, and we use that to confer communication back to our primary care providers. Next slide, please.
Can you hear me okay?
Yep, and so I'm turning it over to Dr. Arfons, a frequent user of eConsults, to talk a bit about some of the workload credit and incentives in this fashion that have helped us to really facilitate the use of eConsults. Go ahead, Dr. Arfons, please.
Great, thank you. I hope you can still hear me.
Yep.
Echo. Okay, so as Dr. Kirsch mentioned, in addition to, I'm getting a really bad echo here. Hold on one second. Okay, are you able to hear me?
Yep.
Okay, very good. I'll just switch to my computer. So as Dr. Kirsch mentioned, in addition to the coding changes, what we also were very lucky is we were approached actually by our productivity management work group, and they asked us if they could increase the VHA related RVUs for eConsults to more closely mirror face-to-face care. So that's what you can see here is the CMS work RVUs compared to VHA work RVUs, and then in the bubble on the right is then the office visit face-to-face comparison. And we did this for also our teleconsultation, teledermatology, the 99451, which is how we use that as well, the VA. And then additionally, as Dr. Kirsch mentioned, I am a medical oncologist, but I'm extremely sensitive to the work that we give our primary care providers when we are asking them to implement eConsult recommendations. And so there was then, for that referring provider usage, some additional workload with the 99452 if they chose to use that. Next slide, please. So pivoting a little bit just to look at a couple of specific VA sites. So this is a lot of work that was done by our Gainesville cardiology group, and they have a fantastic program that is primarily run by a PA, but overseen by one of their cardiologists who actually is joining our office very soon. And you can see here on the left here, there are reasons as to why someone would refer to cardiology. And then on the right is actually what they did with them when they received them from the cardiology team. You can see over 60% were either administrative or minor stable diagnoses that did not require any, either a new consult. If it was administrative, they were arranged for follow-up, or something that really did not need to be seen. Next slide. And what they then were also able to demonstrate just in about under 9 months' time in 2019 is there was a 46% reduction in clinic wait time as they expanded their eConsult use. And in 2019, they were receiving about 1,800 referrals, eConsult referrals through cardiology. Gainesville is a rather large facility, a 1A facility, a lot of complex cases. And so they were able to show that just implementation of eConsults really did positively impact access. Next. Talking a little bit more about the cost, this is actually our data. I am practicing in Cleveland, and I was the sole eConsult provider for hematology in Cleveland, where we deliver about 60 to 80% of our eConsult volume, of our hematology volume by eConsults. And with this, we did show just a cost savings on the medical center side of about $350,000 per year. This does not even take into account the additional cost savings that we calculated for things like beneficiary travel that we give to patients. We also have a heat map looking at cost of gas and miles traveled for our veterans. So it really does, that ultimately showed about another $100,000 over 4 years that did add to the cost savings both on the veteran side and on the VA side. Next slide, please. At this point, Dr. Kirsch, I think I'll turn it back over to you.
And I wanted to make the comment really showing the slides about the workload credit, showing information there really perhaps as further discussion in if there was the perfect system and you could give all the credit in the world and you could get payment and reimbursement, there still are some potential barriers to implementation of eConsults, and so I pose that as perhaps some further thinking as to how what else is there that needs to be done to help people really embrace the utilization of eConsults. So looking at and demonstrating what they can be used for. In the cardiology example, we have found that sharing examples of how eConsults are used has been, that has been a primary mechanism, or one of the mechanisms in which we've expanded and broadened the use of eConsults across the country, and then the wait times and the improvement in access as well. So it's really a multifaceted approach to really supporting providers to engage in this type of work. A few years ago, it was involved really from the beginning to inception of the implementation of eConsults, and have been significantly involved in that over time, more time, sometimes more time than others. But we looked at this, and it was published in the American Journal of Managed Care a few years ago. Across the country, 11 out of 11 million, a little more than 11 million face-to-face consults, and in 13 specialty areas that included some medical specialty and some surgical specialty areas. At that time, there were about 217,000 consults. So that's around 2 e-consults per 100 face-to-face consult requests. We saw, from a prevalence standpoint, the highest in endocrine, hematology, and gastroenterology. And really, we're looking at the growth of eConsult implementation. It was newer back then, and there was significant growth at that time. Of interest, really, I think, is looking at the carbon footprint. We pay our veterans to bring them in and travel. Those are taxpayer dollars. So we looked at the potential average miles saved, and you can see that in that last bullet there, and then potential travel cost savings. That's not necessarily applicable to private sector, but really more so in that the miles potentially saved. And one other aspect of this manuscript, or two, one is that of those patients who had an e-consult, 60% of them were not seen in that same specialty area in follow-up. So it looked as though you weren't just adding care and adding questions, and that's what you inevitably want, is for it to potentially, when it can, take the place of a face-to-face visit. So I thought that was an important component, as well as the rate or the number of e-consults per total face-to-face consults. To me, that seems a bit on the low side. And perhaps that's another point of discussion. What should the rate of e-consults be in a given specialty? And in our discussion, Lisa and I, Dr. Kaiser and I, what we would contend that it may be different in different specialties, and we can potentially get into some detail there in the question and answer session. I think I'll go to the next slide, please. So in some key lessons, I think that we continue to grapple with and want to really continue to learn about, and many of them are applicable to other healthcare systems as well. We did implement workload increases to incentivize behavior, and to some extent that did work. And those, I think, that were doing e-consults, though, really augmented their e-consults. We're looking in and evaluating to what extent that it got providers that weren't doing e-consults to do those. We know that one size can't really fit all, that e-consults is one mechanism. I think that Dr. Kaiser is going to touch on the use of e-consults a little bit further to address some disparities, or a way to give specialty care resources, even in a virtual way, to those that are in more underserved areas or where there may be some healthcare gaps. We do still really see that it is somewhat up to provider comfort in doing so. We've learned that when the e-consult goes back to the primary care provider, that some primary care providers don't want a lot of additional work, that the recommendation goes back, and that it's not surprisingly much more well adopted, that when a primary care provider has a note back from the specialist stating that the specialist placed a number of the orders. So that has been a facilitator also of the e-consult. Lisa's nodding on that one, that she has shared with me that she does that in order to really keep the e-consults flowing. And we know that we are broken up in networks, in regions, thanks to Dr. Kaiser's forethought in the late 90s, and that we are really looking to think about this across the network, so that larger medical centers that have all the specialties can help serve smaller medical centers in a catchment area. I think that may additionally apply to private sector. The question that we always get asked, and perhaps this is the same for many of you, is that what do we see in terms of quality outcomes? For us, that has been a challenge to really understand. We need to understand that there's not an easy way to look at that and understand how comparable that is, and need to continue to think about that. And I think there's another couple of slides back to the pandemic and how we're thinking about virtual care. Dr. Kaiser and I and a few others had a manuscript in New England Journal of Medicine Catalyst. It really speaks not just to eConsults, but really to how we expanded virtual care, including telephone and video to home care. We've made great strides in this arena, and now we need to really focus on maintaining it and continuing in specialty care. I think there's another slide of where we were with eConsults. We saw a huge surge when we had published this into April, May, and June. It looks like a bit of it is digressing. I think we need to look at and address this across all healthcare systems, the augmentation in virtual care. How do we maintain that and not let some of that slip back to virtual care, face-to-face care? And then I want to make a quick comment before I ask for questions in the question and answer box, that you see that large rise in gastroenterology. And interestingly, the gastroenterologists started looking at all the requests for screening and surveillance colonoscopies, and across the country, they were reviewing them to determine whether that was needed care or not. The recommendations are a bit tricky for the 3-year follow-up, the 5-year follow-up, the 10-year follow-up, and that was why you see that spike in gastroenterology, really interestingly. In cardiology, we have a large volume of cardiology patients. And interestingly also, lastly, I'll say is you still don't see a huge rate of eConsults outside of that spike in April and May, and is a fraction of the overall consults that are placed or referrals for specialty care. So that's something to think about as well. And with some of those considerations, and I will turn it back to Dr. Kaiser for some closing comments. Oh, I forgot that one slide, Lisa.
Did you want to comment on this one?
Well, this really speaks to our conversation about this recently, Dr. Kaiser, and that is the maintenance of face-to-face care or the maintenance of virtual care, even when we have face-to-face care as an option. So you can see as we really decremented and increased the face-to-face care, that was more of a swing really in the volume, maintaining a bit the eConsults. And really, if you want to perhaps address some of that thinking around when we do get over this pandemic, and I believe that we need to do that, and that will happen in the next year. How do we still maintain? I will maintain that we will continue to have virtual care delivery, eConsults, and video to home appointments. So I'll turn it over to you, Dr. Kaiser, to if you wanted to comment on that.
Sure, and Timmy, I'm mindful of the clock, so let me just, several things occurred to me in listening to the comments here as well as others today, and I think 3 or 4 questions that come out of this last conversation that are, I think, broadly relevant are the one that, Susie, you already mentioned this issue of what's the right amount of eConsults within a given specialty area. What should be the right percent, if you will, of eConsults versus in-person consults, and that's a question that is going to have to be worked out across the board. We know what works in dermatology may not be the same as in cardiology or oncology or other areas. So we need to put some effort into determining what's the optimal mix of eConsults versus in-person care. I think you also alluded to another really important question that everyone is going to have to face or address going forward, and it's just simply how do we normalize using eConsults as really the default mode going forward. I mean, it should be, at least in my judgment, and I think you would concur, the new normal. And how do we make that happen? How do we make the changes that have occurred as a result of the COVID pandemic stick? And so we don't revert back to what was the case pre-pandemic. And this is really a larger issue of how do we affect culture change in healthcare, which brings, it's a much larger discussion about, how we create the new normal, how we actually change the culture and how people think about eConsults as a sub part of virtual care in general. Two other quick things I would just throw out that I think are relevant is how does eConsults play in with the changing healthcare workforce? New data, I think it's new this week, or at least in the last few days, has indicated that 8% of physician practices have closed since the COVID pandemic started. That's more than 16,000 practices across the country. It's expected that at least that many, if not more, are going to close over the next year or so if things continue as they have been. In California, that's particularly relevant because we know that in many counties in California, about half of the physician workforce was going to retire anyway because of age and other considerations. So there really are some very significant workforce issues going forward. How does eConsults help address that problem? And then the last thing that occurs to me that I think is broadly relevant, and again, Dr. Kirsch, you brought this up, that lack of access to eConsults really is a new health disparity. And we know certainly in the Medi-Cal program, but I would say this is true of Medicaid across the country, that they are not by and large seeing the same amount of access to specialty care that's seen elsewhere, nor are they seeing the benefit of eConsults that in some Medicaid programs are being achieved, such as in LA County or in San Francisco. So how do we think about addressing this new type of health disparity? We have a lot of other health disparities to address as well, but this one adds to the list and is one that should be soluble. So a lot of food for thought in what you covered. And with that, let me stop and turn it back to Timmy, and unless Dr. Kirsch or Dr. Arfons, you wanted to chime in here? Or
nope. I mean, Lisa, if you want to comment, we want to share some experience and see what may resonate or questions you have from this.
I'll jump right off of that, Dr. Kaiser. Thank you for really, helping to summarize, I think, not only what this panel has brought to light, but I think the whole day as well, in those themes around disparity and addressing those disparities and how do we make sure that everything sticks. And part of that is culture change. And I think, Dr. Arfons, what has your experience been on the front lines with being one of the sole eConsult responders of recruiting your peers and working to address that culture change?
Sure, great, thank you. So I think I started doing eConsults when I was the section chief, and I did it because we had a provider leave, and reviewing her panel, I discharged about 75%, transitioned 75% of her practice back to primary care. It was the same note that she was writing over and over and over again, very stable blood work, and I thought, there has to be a better way to do this type of care. And that's how I sort of took off with eConsults. And then intermittently, throughout the years, if my providers would come and say to me, I'm getting too many hematology consults, I don't want to be seeing this much hematology in clinic, I would go back to the data and I would show them, we are providing 60 to 80% of hematology care by way of eConsult. You are not having to see any of that. And so, giving them some perspective and showing them the whole picture, not just of their own practice, but of, the practice of our entire section. That was very important, and sort of reframed their way of thinking. And they thought, oh, I'm not really seeing that much hematology, and you're right, this is probably a better way to do business. So that's on the specialist side. As far as the provider, the primary care provider side, I had always expected my staff, when they were approached by any primary care provider or referring provider, anyone looking for a specialist opinion, to say, how can I help you? And that is our approach, whether we're seeing the veteran face-to-face, if we get an email, if I get an eConsult. And so, I just made it very clear that eConsults were designed to help the referring provider and the veteran. And if it got to the point, even on an individual basis, where a referring provider felt that we were not being helpful by way of an eConsult, then we shut it down and we tried to help them the best that we could outside of that. So I think it's being flexible, showing, your intent, that you are trying to be helpful, not putting up walls as a specialist. And all that can go very far in, painting, I think, a positive picture and promoting a culture of professionalism, regardless of how you're delivering the consult, including the consultative care.
And Dr. Kirsch, thank you. Dr. Kirsch, do you have anything to add there in terms of culture change? I know it must be something you think about a lot.
Well, as someone who's really thought a lot about scaling and spreading this, we just look for continuous communities of practice and sharing the value and how to help primary care and especially care providers engage in this kind of work to be even fun and educational. We found in some qualitative studies that primary care providers enjoy it if specialists put in the eConsult back, learning how to do this better over time. So there are ways to just really continue to create that incentive for further the implementation, even beyond the payment model to incent this.
And Dr. Payan, so the work that I think going back to bringing it back to the patient and how we engage the patient in this eConsult movement, do you have thoughts there? I know it sounds like you are thinking about different campaigns or messaging and working with patients directly. If and how do you think we can make sure that eConsult might be on your agenda?
So I'm coming at it and thinking about it, this equity piece, something I didn't mention in my presentation that has been mentioned by various individuals already are the potential benefits. So this actually does, eConsult has a potential and does address, including other telehealth services, really blatant social determinants of health and issues. So transportation, taking time from the patient perspective, taking time off of work, physically having to leave, and having an eConsult, you reduce another appointment, you reduce the wait time for areas like the Central Valley, which is where I'm located, where I myself have encountered, knowing kind of the population level shortages of specialists and primary care physicians here, it can really already address these issues, but we need to hear from patients and about their perspective from different systems. So how are they being introduced to eConsult? They are part of the system. How is that loop being closed? And some of the work, I love that qualitative research is being mentioned in addition to cost data that's needed, but we can think more strategically actually about documenting the cost savings for the patient who doesn't have to drive to a specialist. How about the savings in not having another interpreter who would have to be there for the specialist visit for certain unlimited English proficiency patients? If we start thinking about these other kinds of, beyond the health systems, perceived benefits and actual benefits and quantify and include them. To identify them, you do need a patient perspective, I would say, but to quantify them and include them in the savings, you can document improve patient experiences and outcomes. And so those are some of the things that in the work that we're doing that's focused on telemedicine, it's like what are other potential barriers that we didn't even think about that people are encountering. So I'm doing some work, another study on broadband access issues and how that's influenced not only healthcare access but educational access this year, and the other types of needs, working from home, being able to do that. Well, your job needs to allow you to do it, but you have to have the technology and broadband as well. And so, I don't expect health services, the people in the health systems who are doing such a great job and have gone above and beyond this year to do it. But I think thinking outside of the walls, how can we partner with other kinds of entities and bring in the patient perspective and what those conditions are? And the patient is one way. Interviews, focus groups, the eConsult toolkit has actually really great surveys from UCSF and focus group interview scripts that could be used for different patient populations. And I would also recommend thinking about these additional questions. What are the cost savings from their perspectives, and what are the benefits, and documenting that as eConsult gets rolled out and implemented.
I wanted to make one brief point about some other earlier qualitative work, and that was that we had patients who shared with us that they probably wouldn't have come to the appointment if they had an appointment with the medical oncologist. I don't know if that's been your experience as well, Dr. Arfons, but we're addressing patients who may not have had a ride to come up to an appointment with a medical specialist in a larger, more metropolitan area, and they would have just not had the care. So I think that's an important point.
And Dr. Kaiser?
Oh, Timmy, yeah, I just throw in two things and borrowing from what we have learned from the patient safety area, as well as from implementing innovations. That there are 2 points I think are important here. And one is that payment and policy changes are not sufficient. And we have certainly seen that in the area of innovation over the last 2 decades, that lots of payment changes, lots of policy changes, but innovation is really not happening, or it's not being broadly adopted. And you have to look at workflow and workforce and other issues than just that. And I think the other, from the patient safety area, the idea that we can borrow is simply that you have to make it easy to do it right and hard to do it wrong. Now, obviously, wrong is not the right word here, but if we want to normalize e-consults, we have to make it easy to do, as Dr. Arfons was talking about. And conversely, you could say, well, let's make it a little harder then to do in person, so that only those who really need the in-person consult are getting them, and the default becomes doing it by electronic means.
Thank you for bringing that back up. I'm always referencing the change and the culture change that we went through with e-prescribing, and right. how hard and difficult it is to be able to replace, pulling out a piece of paper for a script. Which is similar on the referral side. So thank you for bringing that up. I was looking, I actually think with this, when you look back of the day and see all of the muscle we have together, and the networking and the network that we can bring together, and having UC Merced on this panel as well as the VA, what thoughts do you have on where we can take our work group next year? Who are you reflecting on who's missing in this conversation today? And where, I just want to really take advantage of your participation. Where do you think we can be beneficial to your work, and how can we do better work next year? Dr. Kirsch,
actually, I would bring it back to something that Dr. Payan said, and that's bringing in the patient perspective. And really,
it's a bit of a leading question.
Yeah, I mean, understanding what the patient wants and what makes it good for them is something that you might consider including next time.
Thank you. Dr. Kirsch?
Yeah, I would agree with that. You've got me thinking about understanding a little bit more in terms of quality. I've been thinking a little bit about the quality that we really need to demonstrate in order to really help perhaps make even a further case for e-consults. That's in my mind, and the patient perspective. And what we don't stop and say to patients in primary care, do you want to get your care, by asking a specialist a question through eConsult, by having a video visit with them or a telephone call? That, how can we address your care needs best? And that's what's bubbling up a bit for me. So that's what I'm thinking about in furthering this work.
Dr. Kirsch, that highlights something that in the visual I created, I didn't speak to as much, but this what has been an in-person relationship has now shifted to multiple modes, and that will likely be sustained. And we want it to be sustained in many ways, right? But we want it to be done well, and that also means the individuals who are being trained right now need to learn how to start doing that from the get-go in medical school, in residency, in their nursing programs. We need more health informatics, actually, and we need more programs. So because we are moving to doing this effectively, efficiently, but also equitably for patients, we need more diverse people across the spectrum of healthcare, and to learn what eConsult looks like earlier in the game as a possibility, as opposed to what happens now is people learn whatever system they're in, whatever EHR, whatever is there, that's what they're exposed to and learning. But they actually need to learn about the array of options, and I think we need more. I'll push for health communication, more research around patient-provider relationships in these multiple modes and with different patients as well. In California, we really need more. I was really surprised. I've shifted my work over from public health policy to health services research this year because I realized the patient perspective in telemedicine implementation, there wasn't a lot there in the research, and we need more robust research to support what the actual patient experiences are from, during a crisis. And so that means we have to do it quickly, but we have to do it well to inform policy. So Dr. Kirsch and Dr. Kaiser, I really like those comments thinking about the patient. And I think I'm pushing back a little bit. I'm outside of health services, so I'm trying to connect the clinic and health services to what happens outside, which we know certainly influences health outcomes.
Might be something to follow up on with the panel right here, is to think about some research together. I'll just put that seed out there. And also, I have another question that just came in from the Q&A of thinking about behavioral health. And Dr. Kirsch and Dr. Arfons, you both talked about eConsult and being used for behavioral health. But do you have a use case or a thought around how eConsult might be helping with the pandemic and the social isolation that some of your veterans may be going through?
It's a very good question. I know as far as telephone care, that mental health really has been a leader in both telephone and video. They pivoted extremely quickly to deliver both, and obviously to check in on veterans. So I think that has been a good example. I think as far as the eConsult use in particular, not immediately. We are going to be looking at preventive health services and doing some of that research and bundling and looking what has been missed perhaps during the pandemic as far as screening mammography, colonoscopies, and also mental health assessment as well, along with diabetes, all those. And so I think keeping obviously mental health checks right up there, that if you're reviewing something electronically and you're looking at the medical record and something is missing, to make sure that you're reaching out to that veteran for not just physical reasons, but also mental health reasons as well. But Susan, anything else? Oh, you're muted, Susan.
One example I recall from a few years ago in trying out different things in getting eConsults to work was the specialist, without going from primary care to specialty care back to primary care, was that the specialists identified populations of patients. And I recall there was a rheumatologist in Salt Lake City that did this for osteoporosis. And when there were patients that were on certain medications that increased the risk for osteoporosis, or patients that had some COPD emphysema that were on certain medications that perhaps they could come off. It was a proactive population approach to reach to the primary care providers and do almost a reverse eConsult to say, what are you doing? Well, that doesn't sound really probably politically correct. What are you doing? But may I advise you that this may not be the most in accordance with clinic practice guidelines, and would you be willing to consider X, Y, and Z in terms of ordering a bone density or discontinuing a certain medication. So to tie that to Dr. Arfons and the preventive health services, we're looking right now at the PHQ-9 and utilization of depression screening. And I think that we can do almost that same thing and reach from the specialty side, the psychologists, social workers, and mental health providers out to primary care asking if I see a patient coming up on your schedule, or there are patients that may we've seen that could benefit from an outreach in eConsult. Just thinking about.
I'm so glad that this came up. That question was, I'm so glad that question came up, because that's something that, especially with the pandemic and looking at the long backlog of where and how the health plans who have a lot of that information on whether there was a specialty visit, referred, and yet there was maybe a no-show. Or to be able to see where there might be some better intervention made at the primary care and can be done there, that's exactly, I think, in our roadmap. And I'm so pleased that came up. Thank you so much.
So, Timmy, is at least anecdotal evidence. I mean, it's not eConsult per se, but there's at least some good anecdotal evidence that virtual care, when it is utilized frequently, is effective in dealing with some of the social isolation issues related to the pandemic. That even brief phone calls, if they're done frequently, can ameliorate some of that isolation that people are feeling, which may be particularly important for those who have behavioral health diagnoses. So I haven't seen published studies, but the anecdotal stuff is good.
With a reminder to all of us to make a few phone calls this afternoon. So thank you. And I'm just going to wrap with that. Thank you so much for participating, giving your time to us today.